movement. That can be voluntary movements and automatic movements. And these syndromes or disorders, they are not related to weakness or spasticity, motor weakness or spasticity. For example, in case of a stroke, there is weakness. A stroke patient also have difficulty in locomotion and movement, but it is not a disorder of movement syndromes, because it is disorder associated with direct cortical control dysfunction. There are two types of movement disorders. One which are hypokinetic, are also called akinetic rigid syndrome, and other hyperkinetic. What are hypokinetic disorders? These are the disorders that result in paucity or slowness of movement. And hyperkinetic disorders are the disorders which are characterized by excess involuntary movements. Hypokinetic or akinetic rigid syndrome, the hallmark or the important syndrome in hypokinetic disorder is the Parkinson disease and other causes of Parkinsonism. For example, Parkinson plus disorders or PD plus disorders like PSP, progressive supranuclear palsy, MSA, multisystem atrophy, corticobasal ganglionic degeneration, Wilson disease. Also, hypokinetic disorder resulting from hydrocephalus, like in normal pressure hydrocephalus, NPH, Lewy body disease. So these disorders are characterized by bradykinesia or akinesia, means slowness in movement, rigidity, tremor at rest, postural instability, inflection posture, and gait difficulties or gait freezing. What are hyperkinetic disorders? Hyperkinetic disorders, common disorders include chorea, dystonia, myoclonus, restless leg syndrome, tremor, tic disorder. Other less common disorders include, and these are also not very well defined in hyper or hypokinetic disorders, for example, akathletic movements, balismus, athetosis, myokemia, and paroxysmal dyskinesias. So the list of disorders, common disorders, should be borne in mind when you are talking about hyperkinetic disorders. Most of these disorders, but not all, they are resulting from some element of basal ganglia dysfunction. So that's why they are also called extrapyramidal disorders. As you can see in this picture, basal ganglia structures, caudate nucleus, thalamus. This is putamen with internal segment and external segment, subthalamic nucleus, and sustension nigra. This is circuit and loop that is involved in the abnormal either excess movements or paucity or slowness of movements. You must know that basal ganglia do not connect directly to spinal neurons. We know that. I will show you later. It exerts its influence indirectly via corticospinal, tactospinal, and reticulospinal pathways. So lack of direct sensory input and motor outputs from the basal ganglia suggests that they act as modulators rather than executors of movement. Basically, cortex is the executor of movement, which controls directly through descending pathways to spinal cord. These basal ganglia structures, they actually modulate the execution of cortex for different movements. So the connection of basal ganglia with cortex, cortex sends projections to striatum, striatum through its output source pallidum sends projections to thalamus, and thalamus back to cortex, and through this cortex then spinal neurons. You can see in this picture the pathophysiological concept of movement disorders, that the direct control is through cerebral cortex, through descending, ascending projections to spinal cord and muscles. But basal ganglia and cerebellum on sides, they act as the modulators, or you can see the coordinators of movements. So basal ganglia, through indirect connections with brainstem, thalamus, and cerebral cortex modulates the movements of the body and modulates the output of the cerebral cortex. Similarly, cerebellum also modulates these movements and acts as a basically center where the smoothness and coordination of movement is modulated. So this basal ganglia and cerebellum, they are not directly controller of the movements, but dysfunction in these structures can lead to movement disorders. For example, in Parkinson disease, there is degeneration of nigrostriatal pathway leading to slowness of movements. And if there is dysfunction of cerebellum, it will cause ataxic movement. Now we will discuss about the main movement disorder, the well-known movement disorder called Parkinson disease. What is Parkinsonism? Parkinsonism is basically the cardinal tetrad of Parkinsonism includes tremor, rigidity, bradykinesia, akinesia, and postural instability. The most common cause of Parkinsonism is Parkinson's disease. So Parkinson's disease is an idiopathic disease. While the causes of Parkinsonism are many, it is the second most common cause of neurodegenerative diseases after Alzheimer's disease, and it affects around 2% of the population over 60 years. Majority of Parkinson's disease cases are sporadic, means without family history, but inherited form of Parkinson's disease also occur mostly at younger age, which are called young Parkinson's disease. Main pathologic process, as we have been studying since our neuroanatomy classes, main pathologic process in Parkinson's disease is the degeneration of dopaminergic neurons in the substantia nigra, which is a part of midbrain. But actually the mechanism responsible for neuronal degeneration is probably multifactorial and based on a combination of genetic and environmental factors. So substantia nigra, there is loss of neurons. In Parkinson's disease, 70 to 80% loss of neurons already when there is symptom. And in intact neurons, you will see the Levy bodies, which are cytoplasmic inclusions. Nigrostriatal dopamine loss and severity of motor symptoms are correlated. More severe nigrostriatal dopamine loss, more severe motor symptoms. And nigrostriatal dopamine loss will lead to what? Reduced activation of dopamine receptors in basal ganglia, and there is an increased striatal cholinergic activity causing different forms of manifestations, motor manifestations like tremor, rigidity, bradykinesia, and postural instability. Here you can see the normal midbrain substantia nigra, where midbrain you must have seen before, there is pigmented area normally which contain dopaminergic neurons, while in case of Parkinson's disease this pigmented area is lost. These are the nigrostriatal projections that are responsible for motor manifestations in Parkinson's disease. The loss of dopaminergic projections from this area of midbrain will lead to various motor manifestation because it sends projections to this putamen and caudate nucleus called striatum, and it modulates the motor activity. If there is loss of this nigrostriatal pathway because of deficiency of dopamine, there will be many motor manifestations that we have discussed. This is the same. Basically, there is, you can see in Parkinson affected patients, there is this loss of nigrostriatal pathway and neurons will lead to very less release of dopamine. As you can see in normal patients, there is normal release of dopamine and normal movements, and therefore here there's movement issues when there is very less release of dopamine in neuronal synapses, leading to tremor, slowness of movement, and rigidity. As I discussed, The actual mechanism responsible for death of dopaminergic neurons in substantia nigra pars compacta is basically multifactorial. It is not a simple. There are environmental factors, very important, MTP exposure. There are genetic mutations, various genetic mutations, oxidative stresses in excitotoxicity and mitochondrial dysfunctions. They can contribute in different ways to ultimately damage the neurons in the substantia nigra pars compacta and leading to manifestations of Parkinson disease. Here in this picture you can see the important symptoms and signs of patients with Parkinson disease. As you can see, very stooped posture of this patient. Stooped posture with mask-like facies means expressionless facies. There you will see a pill rolling type of asymmetric resting tremor. On examination you can see there is postural instability, shuffling steps, freezing. You can see also or check for rigidity with passive movements at wrist and elbow, and there will be reduced arm swing with overall slowed movement and Parkinsonian gait. So what are the motor symptoms of Parkinson disease and non-motor symptoms of Parkinson disease? Motor symptoms of Parkinson disease that are usually more marked and seen by everyone, but there are equally important non-motor symptoms as well. So motor symptoms: resting tremor, rigidity, bradykinesia, postural instability, fascinating gait, micrographia, mask facies, and retropulsion. You may see that is hypophonic speech or soft speech in patients with Parkinson disease. Non-motor symptoms include constipation, autonomic dysfunction, impaired olfaction or loss of sense of smell, dementia ultimately in many patients, depression, sleep disorders, impulse control disorders, and psychosis. Diagnosis of Parkinson disease is mainly clinical. There is no single laboratory or imaging test that is confirmatory for diagnosis of Parkinson disease, but you can see on PET scan, positive emission tomography scan, that there is decreased uptake of fluorodopa in Parkinson disease compared to healthy control patients. Here you can see potominal uptake of normal fluorodopa dye, but in case of Parkinson disease, initially there is asymmetric uptake in one side of the basal ganglia or putamen, while it's normal on other side, but ultimately there is decreased uptake of fluorodopa on both sides in case of advanced Parkinson disease. We know that Parkinson disease is a progressive neurodegenerative disorder, so there is up to this time there is not a single treatment strategy that can cure or reverse this neurodegenerative process, but there are many treatments that are very effective symptomatically, and these treatments, because dopamine deficiency is the main cause, or dopamine deficiency is the main cause for many motor symptoms, so the replacement of dopamine with dopaminergic medication is the major medical therapy for majority of these motor symptoms in patients with Parkinson disease. Non-dopaminergic medications like anticholinergics, anti-glutaminergics, and muscle relaxants are also used to treat motor symptoms. And the non-dopaminergic medications are also used for the non-motor symptoms like dementia, sleep disorders, anxiety, etc. What are dopaminergic medications? The most important is a dopamine precursor called levodopa, which is basically precursor of dopamine, and it is converted to dopamine in the brain, and it is given usually with carbidopa, which inhibits its peripheral conversion to active form of dopamine. Dopamine agonists like bromocriptine, pramipexole, ropinirole, apomorphine, these are direct dopamine agonists, and this is dopamine precursor. These COMT inhibitors and monoamine oxidase B inhibitors, basically they increase the level of dopamine at synapses because they inhibit the degradation and metabolism of dopamine. COMT inhibitors, which is called catechol O-methyltransferase inhibitors, these include entacapone, tolcapone, Monoamine oxidase B inhibitors include selagelene and rasagiline. Non-dopaminergic medications used for treatment of Parkinson's disease include anticholinergics, because we know cholinergic activity is increased in case of Parkinson's disease. Anticholinergics include trihexyphenidyl, diphenhydramine, amitriptyline. Antiglutaminergics include amantadine. GABAergic drugs like lorazepam or clozapam are also commonly used, and atypical neuroleptics, not typical neuroleptics, but typical neuroleptics will aggravate the motor symptoms of Parkinson's disease. So atypical neuroleptics like quetiapine and clozapine are also used for sometimes for non-motor symptoms like psychosis and other symptoms. Surgical treatment have been option for advanced Parkinson's disease since 1950s, and usually it was unilateral stereotactic lesioning of the pallidum called pallidotomy or thalamotomy, which have been used to reduce the symptoms of Parkinson's disease. But the development of DBS, called deep brain stimulation, has revolutionized the surgical treatment of advanced Parkinson's disease. In DBS, basically electrodes are placed into the specific sites in basal ganglia, and they are attached with a pulse generator which is placed below the clavicle on either side, and it generates high frequency electrical stimulations. That's why it actually acts as a stimulator of the basal ganglia structures, which are inhibited because of dopamine deficiency. Here you can see the placement of leads in the basal ganglia structures. They are placed on both sides but connected to a wire on one side, and it is connected to a pulse generator here, which is battery placed below the subclavicle, and basically this is where from the electrical stimulation excites the basal ganglia structures, which are inhibited or dysfunctional because of dopamine deficiency. And it is very effective form of surgical therapy for advanced Parkinson's disease, and it controls almost all cardinal symptoms of Parkinson's disease like rigidity, bradykinesia, tremor, and other symptoms. So this was briefly about movement disorders in Parkinson's disease. I hope I have covered the major things, but maybe I can upload a more detailed form of this lecture in my subsequent lectures. Thank you very much. And I will be waiting for your questions in this regard. Thank you.